Welcome everybody to this session. I'm Peter Bradley, the chair of the session today, unexpectedly. I'm Director of Knowledge and Intelligence in Public Health England, and we're going to hear from our speakers today who are going to tell us about digital and how that works in public health practice. So our intention is we're going to hear from the speakers first, and then we will have time for questions after that. So our speakers are David Sweeney, who's the Interim Chief Operating Officer at Halton CCG. We've got Hannah Bowden, who is the Programme Director at Better Points. Julie Bretland, who's the Managing Director at Our Mobile Health. And Dr. Mary Black, who's a Senior Advisor to Digital and Data Science in Public Health England. So to set this in a bit of context, my background is general public health, and I've learned over the last couple of years how important digital is to improving our public health offer and being innovative. And I have found I've been on a really steep learning curve. There's lots of jargon, but at the end of the day, I've realized that this is really about producing things that are more suitable, more appropriate, more flexible for our very dynamic world. And I think that's what we're going to hear about today. And just a little plug from the digital team in Public Health England, they do have a strategy that does demystify some of the concepts. So if you would like to look at that on the website, I'm sure they'd be very pleased. So I'm going to hand over to our first speaker now, Dave Sweeney, who's going to take us through some very interesting work in the Northwest.
Good afternoon, everyone. Great to be here. I've just whizzed it up to from Expo in Manchester, here with all the great and the good, and that's been fab. And I may get time to go back to be in front of Jeremy Hunt, or I may not. Okay, so my name's Dave Sweeney. I'm the interim chief officer or chief executive, whatever you want to call him, of Halton CCG, and I'm just going to take you through a bit of a journey. So in this 5 minutes that I've got, I'm not going to kind of labour too much on the actual specifics of the work, just in terms of how we've turned this into core business. Because what I'm very proud to say in front of the great and the good and the brilliant public health minds that we've got in front of here, that we kind of get this, and I get it, and my board gets it, my chair gets it, and our population get it. Because you guys have been pushing prevention, you've been pushing social prescribing, you've been pushing the early start in life, you've been pushing all that for many, many years. And I think we're at a tipping point now where things are really starting to rock and roll. In Expo, everyone has been talking about social prescribing, everyone, from Andy Burnham, obviously Duncan was there, he was speaking as well. Prevention is the arm of everything we're doing. So let's work on that, and let's start a revolution, or a call to action as we like to call them. But this is something like that. So we wanted to do, we followed the kind of Sterling Mile, like I know a lot of us have, and we wanted to do, let's do something about that. But we were about to launch our cultural manifesto, and I got into a little bit of trouble because I launched it in front of Prince Charles at the King's Fund in Purda. So that went down well, and as I said, ladies and gentlemen, this is the only manifesto that counts right now. It's a cultural manifesto, so I got a bit of a ticking off, but I like to work on the premise that you can kind of apologise afterwards, can't you, if you get your stuff in. And it seemed to really resonate with the crowd, because we're skint, we're brassic, we're broke, we know that. And you'll hear that from your CCGs, you'll hear that from your investors or whoever that is. And when you want to do your preventative stuff, the cupboard is bare, because we can't take the money out of the hospitals, la, 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 you know the story. Okay, but what the Cultural Manifesto does is start to work on assets and start to work on the stuff that we've got in our town, the stuff that we do know works, the green spaces, the environment. And one of the major assets that we had that we kind of stumbled across was a rugby team. The Widnes Vikings have been around since 1860-odd. They're not doing too well at the minute, fingers crossed. But huge amounts of assets, right? Nobody listens to doctors anymore. I'm afraid the clinicians in the room, I'm really sorry. But the population, it's a tough one. But you know what? When you've got a massive pair of biceps and a big pair of thighs, it really starts to kind of resonate. And it kind of, doesn't float my boat, but, I sometimes wish it did. But what it does do, is start to kind of change the message. Now, when we thought we want to target kids, we want to go out and speak and get kids rallied, to use the Sterling Mile as that kind of pivotal thing. But what are we going to do? So we call it Game Changer. So we said to the team, the rugby team, just go off and come up with something different. And they did. Game Changer. So we did it right across every school, and it was a high intensive input into the schools with the kids, doing all kinds of different activities. It was core in the school. It was 80 minutes a day, and we started to see some really, really interesting things. We wanted to measure this as well. Again, did the digi side of things. We wanted to measure it, so we hunkered in with Sopostera, a French organisation. They developed a wearable for us. Every kid had a wearable that then went back into a tracker, and every time the kid walked into the classroom, it tracked the activity. Much more I can tell you about that, but in this time that we've got, I'm not going to be able to do that. But I can, we can connect and do that later, because I would really like to show you the trackers. It's working really, really well. So making sure that the baselines that we got with these kids, making sure that obviously from an evidence-based point of view and evaluation, we can do what we're doing. And it just started to take off. The school started to really, really resonate and really kind of get on the back of this. Because the idea is we can't sustain this going forward all the time. The schools have got to get into the core. So 2 schools have bought a gym since. One school, it's incredible, you have to see it, have put a salt course in at the front of the school that you have to do before you get into school. It's brilliant. Some of the teachers try and do it. One bloke, a little bit bigger than me, I'd say, he's bordering on the 15.5 stone mark, got stuck in the ropes, his teacher, to the hilarity of the school, as you can imagine. So they're just doing things really differently. And again, it's not rocket science, this. It was just about sparking the imagination of the schools, and the rugby players did it with aplomb, because the kids love them, male and female. One of the critics we had was, how does this work for young women? Trust me, our girls absolutely love it. Absolutely love it. They're famous. So this is the kind of stuff that we've done, and it won't be anything different than that's what's going on in all of your boroughs, I would imagine. But making sure it becomes core and part and parcel of what the school does. Okay. Whilst we've got some brilliant speakers here, I just want to move into the most important bit. So after the baseline assessment, so 63% improved their standing long jump, and it was amazing. You take for granted that kids jump, don't they? But a lot of the kids didn't know how to jump, didn't actually know from a standing point to. I just found this fascinating, and really couldn't jump. I mean, some kids were so out of shape they couldn't actually jump, but 63% of them improved that. The hand grip strength, 60% improved, 6% the bleep test score. And that bleep test was hardcore, okay? There was a lot of red puce faces as that was doing it, and 65% have increased the fitness from doing that, and it's all evidence-based stuff. And 50% impressed the shuttle test score as well. So the schools are doing it as they want to do it now. We're allowing them to go on, and the rugby teams will be supporting that into next year as well. This is the second tranche of data of the 24-week. Now, what's in there as well, and I've left it out because I've left it on purpose, there's a weight loss scenario as well. There's something like 62% of those kids have lost weight. And we've had a bit of criticism of that, is that, why would you be forcing, or why would you be promoting kids to lose weight? But those were the kids that were above that obesity, and well above some of those obesity levels. We had one family in there that mum was, I guess, embarrassed really when we were in the assembly, because her daughter had lost so much weight, and she couldn't believe that they got to that point where her daughter was so obese. And between the whole family now, the whole family have lost a combination of 42 stone, would you believe? And we can say nothing more that they were inspired in that assembly, inspired by the players, not by the people wearing the badges. Trust me, we didn't inspire that family. The rugby players did. This is the next data, and as you can see, as the tracker is tracking all these kind of things, we're getting rich data from it on a continual basis. So, in the time that we've got, I couldn't go into the kind of minute detail. I just want to give you a kind of a lasting message, right? You are all system leaders in this room, in one way or another, okay? This is great. We love this, but there's tons of stuff that's going on here. There's tons of stuff that you're going to hear from my fellow colleagues on the panel, right? The time now for social prescribing, the time now to get this kind of stuff into core business, not just a nice thing to do, into core business is all our jobs in this room, and we're on the tipping point. So if you can celebrate, and we can all celebrate this and get that evidence base behind us, we're on a definite move to something really different. So I'm proud as a CCG Chief Officer to stand in front of you to say, I get it, we get it, and you know, tons of people are getting it. So keep that rally and keep that core, because we're reliant on public health and the great minds in this room to actually change this dynamic and change the way health system and leaders work, and we need that, and we have to have that. So that's my plea to you. We can have a brew, a coffee, or a pint after, if that's allowed in a public health conference. I'm sure it is. And I'd love to catch up, so I'm going to be hanging around later. So thank you very much for your time. Thank you.
Thank you very much. And now we have Hannah from Better Points, who's going to explain the relation between digital and behaviour change.
I'm going to talk about the challenges and achievements we've got, not the relationship between digital and behaviour change, but I'll touch on that a little bit. Yeah, thank you very much, Peter. So, yeah, my name is Hannah Bowden, as you've already know, and I'm Programme Director for Better Points. So I'm responsible for the design and implementation of the digital behaviour change programmes that we deliver for CCGs and NHS trusts. And as I said, I have been asked to talk about some of the challenges and achievements that we've made in delivering that in practice over the last 4 years that I've been working with Better Points. And I was going to bring you some data and case studies, but I decided that was a little bit boring. So instead, I'm going to be a little bit bold and tell you what I really think about some of the real challenges. Typically, physical activity interventions, digital or otherwise, are plagued by low engagement. The expense of the interventions and the cost is always an issue. Nobody's got any money. And the ability to scale them is something that is always a challenge. Very often we get good results, but with very low numbers, or we seem to get really good results, which are all about the high numbers, but with no real evidence of behaviour change. And we're always really nervous, as I'm sure you all are, about looking like we're wasting money on these kind of interventions. We don't want to look like we're wasting public money. And so because of the fear of failure, we tend to gloss up the results, make it look like the intervention's been more successful perhaps than it actually has been. And this in turn is meaning that we just carry on doing more of the same, getting more mediocre results, and generally not achieving what we'd really like to do from a behaviour change standpoint. And meanwhile, we are getting fatter, less fit, and more expensive. And quite often, good products, like technologies like Better Points, just don't make it out of the beach because of the NHS procurement breakers. So our biggest achievement to date really has just been pure survival. And I'd love to be able to stand here in front of you and tell you about some sort of breakthrough business model or amazing technical advance that we've come up with that has allowed us to do this. But the reality is that it's been more about good luck than good design. And in particular, it's been about the unwavering support of our angel investors who have invested in us for social good and allowed us to get to the point where we can actually gain some real market traction. But it really isn't all plain sailing, and engagement still remains a massive challenge for us. And that's not just engagement of the end users, but it's also engagement of our partners and key stakeholders within the communities that we're delivering the interventions. And critically, the community leaders in those places, because without them, a digital intervention, no matter how good it is never going to work on the ground. So as well as engagement, the biggest challenge that I see, and this is what I've alluded to a little already, is courage. It's about having the courage to look at real evidence of our programmes, not just sheer numbers, and to say, has this really worked? And then having the courage to actually say no if it hasn't, and then try something different. And without that kind of real honest appraisal of our programmes, then we are just going to keep on doing more of the same, delivering and rolling out digital interventions that are more one-size-fits-all. And we're never going to get the results that we really want, because behaviour change is a very difficult problem. So, in the spirit of honesty and courage, I'm going to share one of our abject failures with you. And this was a 6-month programme for a CCG. It was an employee wellbeing programme, and it was integrated with Workplace Challenge. And it was designed so that end users could earn vouchers for getting more physically active, and then redeem those and for rewards for a local charity. And we had next to no engagement in this programme. And I think the reason why is because it was an unfunded pilot, and this is one of the procurement breakers that I was mentioning earlier. And as an unfunded pilot, we couldn't give it the time and attention that it needed to drive it. And also, our partners just didn't buy into it. And quite honestly, the end users just didn't get it at all. It was too difficult, there was too much faff around the login, there was 2 apps, there was no clear messaging about what the rewards and the points were all about. And on the whole, it just didn't work. It was a classic example of something that was business and technology driven, an unfunded pilot that didn't take the end user needs and wants into account. But in contrast to this, when you really do invest in programmes and take a chance on something new, and partners are properly bought in, and we have enough time in the groundwork, setting the promotions in place, engaging with the key stakeholders that are going to be involved on the ground, then a digital behaviour change intervention really can work. There is demand for it, it can scale, and it can be cost effective, even with financial incentives designed to elicit that external motivation to get people moving who don't really want to do anything. An example of this is a programme that's currently coming to a close that we've been working on in Bologna in Italy. And there we've got, again, a 6-month programme, and we've got nearly 22,000 people engaged, and they collectively have done more than 1 million activities. And on a smaller scale, but with real evidence of behaviour change from tracked activity using a smartphone, not from self-reports, we've seen 80% of people move from inactive to active in a physical activity programme in Birmingham. And a lot of those people are still using the app 2 years later and reporting that it's helping them to maintain those activity levels. So the future is bright for digital, but we can't rest on our laurels. And what we need to do is we need to identify the key active ingredients in our interventions, and this is an achievement that I'm currently quite proud of. So we find these active ingredients and we combine them in different ways for different audiences, and we go out to the market and we test them with our army of beta testers, and we get their feedback and we listen to what they like and don't like about the features and the functionality. And then we take this intelligence and we change it up again by the use of our flexible digital platform, which allows us to do that. So we're able to fail fast and iterate. And we do this on a 2-weekly cycle. And the challenge that we're working on today, that I really get excited about, is how we can then take all of that information and we can use it to develop and train machine learning algorithms that can then make that fail fast and iteration process even quicker. We can bring in multiple variables that we couldn't handle with our human intelligence alone, and we can drill right down to the individual level, because one size fits all is just not going to cut it anymore. And really, if we're honest about the evidence and the results that we want to see in behaviour change, it never actually did. So combining the best of machine and human intelligence is not only going to allow us, as challenging as it may be, it's not only going to allow us to drill down to the individual level, but it's also going to allow us to automate the scaling up to the population challenges that we're all facing. Thank you.
So we're now going to move on to Julie Bretland, who's going to talk from our mobile health about apps and how we look at those.
Yes, there's obviously a bit of a theme this afternoon. So my name's Julie Bretland. I'm from an organisation called Our Mobile Health, and I'll tell you a little bit about the work we've been doing for the last 2 years, actually, with the Public Health England team, which we've thoroughly enjoyed doing. So Our Mobile Health was very specifically set up to assess digital health services, by which we talk about apps, but actually it's broader than apps. And as many of you know, although apps have a slightly, or not necessarily perceived often in the best way, they're regarded as slightly frivolous, actually apps can do an awful lot of good, so as we've seen. So we were set up to provide confidence for health care professionals, public health professionals, to recommend apps, to deploy apps amongst their staff, and to socially prescribe apps. And I'll come back to that as well in a bit. But the big thing that we talk about is to be able to do all of those things with confidence. So to give you a bit of context as to the sort of apps market, we take part in a big piece of research every year, and the last piece of research showed us that there's over 259,000 health apps out there. So that's an awful lot available to us in the health and medical category. It's estimated there's about 500 million users of health apps now, and by that we mean anything from, helping us remember to walk 10,000 steps a day, teaching us about how much sleep we actually need, whether we had good sleep, what our nutrition's like, helping us to cut down on our drink, on our sugar, but also some of the more, I suppose, medically orientated areas. So if you're suffering from a particular long-term condition, how do you manage that? If you've got elderly relatives, managing their care, etc. So there's a number of things like that. It's often thought that these are, apps, they're really easy to develop. They're published, by a man and his dog sitting in his garage. That's actually not the case anymore. These are quite sophisticated companies. They're typically around 300, 400 people in terms of the size of the company that's publishing this. It accounts for about 5% of the total app market, so it's still relatively young. But interestingly, it's been growing 35% year on year for the last 2 years. So it is one of the fastest growing areas of apps in general. And it accounts for about 3 billion downloads now. So if you look around the room, you've all just had lunch, I'll do the quick hands up if you've got a health app on your phone. Now you see, I stood here a couple of years ago and asked exactly the same question, and pretty much 90% of you have just put your hands up. So we're either speaking to the converted, or you've all been trying this just before you got here. I trust we're probably speaking to the converted. But I did it a couple of years ago, and actually it was only about 20%. So you can see the dramatic increase just in the last couple of years. It's an attractive market because of this, because we're all hearing about it everywhere. It's rumoured to be about 47 billion in terms of size. So everybody is rushing into this space. But actually, it's really tough, as we've just heard, to actually even make a return on the development. And the development costs are but a very small, minute part of the overall costs of development and launch and maintenance and ongoing evolution of an app. So there's some of the, Hannah touched on it very, very well in terms of some of the challenges that the apps are facing. And it's one of the big things that they're also facing is not just, can they actually survive to recover even their investment, and have they got nice investors, but also this big issue of discovery. So the big thing is, you launch on an app store and voila, your millions are made, and you'll have all these happy users leading healthy lives. But actually, that's often not the case. The app stores only show the top sort of 1,000 apps. It's really difficult to actually find the one that you want to work with. So one of the interesting things we found is that we're all quite happy when it comes to our well-being. You know, if we're already healthy, we're quite happy to go onto the App Store and learn how to do yoga poses, for example. But once it comes into something a bit more on the medical side, actually we turn to those we trust. We turn to our health professionals to ask them what would they recommend. And that's an interesting one, because lots of people don't necessarily have the book or the library on their shelves as they're used to with drugs, to just be able to take it down and say, oh yes, you need X, Y, Z. So that's the other challenge that we face. And it's difficult to do that in an already busy day job. So with all rightly so, they're absolutely wary of prescribing things that they're not entirely comfortable with and they're not entirely sure about. We work a lot with Professor Jeremy Wyatt from the Digital Health Institute in Warwick and Leeds, now based down in Southampton. And he did some work a couple of years ago showing that actually the good apps don't necessarily float to the top. There's an inverse relationship between those at the top of the App Store and those that are actually evidence-based. And if you think about it, and take a step back and think about it, that's partially because the people that are good at health interventions, that are good at developing these sort of insights, aren't necessarily the same people that realise that there's a huge marketing industry that sits behind the app stores trying to get the app stores into the top 10. So that's where we come in, and we try to help the digital health providers sort of overcome some of these challenges. So we help very specifically to identify, assess, and then review and curate apps. And that's really what we've been working with the National Information Board, which was, National Information Board Health Apps and Wearables, now Domain A programme, was run by Public Health England, yourselves, and NICE, latterly also working with NHS Digital, who have now taken over the work. So we spend a lot of time actually identifying relevant apps and apps that are good. We work with the self-assessment programme that has been co-developed over these last few years with all the good input from a number of different expert stakeholders. So there's a self-assessment programme that then goes to the app developers, about 300 questions. We then get an expert review. So this is the coming together of the sort of digital world, regulations that are changing all the time, but also the traditional health world. So it's getting that expert peer review in there was also important. And then we put those into an app library. So a bit about the assessment process. This has been literally painstaking work for those of you that have been involved with this for the last number of years. But a couple of things to look at when you're judging apps and digital interventions are things like, okay, regulations are changing an awful lot over the next coming years. Are they a medical device? Should they be a medical device? Are they under the sort of auspices of the CQC, for example? Privacy and confidentiality. This is a great way of engaging with users, but are you being transparent with your users about what you're doing with the data, where you're taking it, what research you're doing with that? All that sort of stuff. There's a regulation coming in called GDPR, General Privacy Regulation, I think GDPR, General Data Privacy Regulation. And that's all about actually collecting users' data. Once you have collected that data, one of the things that you need to be thinking about is where you're storing that data, where you're hosting it, in particular if you're hosting it in England, if you've got services here. Effectiveness is that sort of evidence base that we look at. Clinical safety absolutely goes without saying, really important. But as is usability. So one of the things that's been touched on earlier is this process of engagement. It's no use having a really boring app and prescribing a really boring app that somebody downloads and then isn't going to ever use again because they just can't get the hang of it or it doesn't work for them, etc. So usability and accessibility. If you're targeting a particular sort of therapy area, are your target audience actually able to use it? Interoperability, again, you're moving data around. Where are you moving it? Are you being transparent about that? What other apps are you working with? Change management. Actually, we want apps to continue to develop. They need to continue to develop and evolve as they go forward. It's a really fast way of reiterating and taking that learning and putting it straight into the app again. And technical stability. One of the famous ones is if you're working with an app, the last thing you want is for it to fall over because the operating system has been upgraded. And talking about taking this into core business, so one of the things that we were launching at Expo yesterday is an app library that can now be prescribed from a GP's workflow, so that you can now go into a GP environment and actually be prescribed an app. So this was really exciting for us, and it's a real way of that prevention agenda getting right onto the desktop of the GP. So we're doing it by stealth, if nothing else, at the moment. And on that note, I'd like to say thank you very much and hand over to Mary.
So Mary Black is now going to talk about some of the strategic issues for digital and putting digital first.
Hi, everybody. So this is what the world looks like now. And in a few years' time, she's going to be a screenager. And this is what she's really thinking. And I think it's what we sometimes think in Skipton House on a bad day as well. So it's because we cannot conceive now of what it was like before the internet. So when we lose it, when it goes down, we're actually quite stuck. And we live in a country where the UK government is ranked #1 on the UN Index of Digital Government, which is quite remarkable. I didn't mean that to sound cynical, by the way, so I'm not quite sure why you're laughing. It shows you how far we've come, and Public Health England is part of government, so there's a real opportunity there. The Department of Health talks about digital first. Government is digital by default, which means you must do digital first for services. Department of Health recognises health's a bit more complex. And we are digital first as well. So in February, we launched the digital strategy, and it's actually quite a good read and was even trending for a while. So do have a look. And of course, let's look at how far we've come. So here we are at the Public Health England conference, and my next slide is dedicated to Felix Greaves, who's at the top, up at the back, Felix. And that is, he's very excited about the disco tonight. So this was us maybe a few years ago at dancing, and we don't dance this way anymore. And it's somehow, well, Felix does, but it's somehow changed over time, subtly. 3 years ago, there was not much on data science or digital at this conference. There was hardly anything, right? And there's loads now. Judging the e-posters, there were so many of them about people who are trialing and using digital technology and data science. And we're also in the main room. So that change has happened quite suddenly. And I think the tanker has turned. And in fact, what is really happening at the moment between marketing, digital, and data science and our partners is extraordinary. So we've gone beyond the sugar app now. That was quite innovative. We're now to much more creative kinds of things. And it's right across the whole public health community. So you see it happening in CCGs, local authorities. It's all shifting. It's all changing. And we can answer questions now that we could not even ask before. So if you think about it, we have real-time data, projections, and modeling, and we've got data science. So there are only really 5 questions that data science can answer. So the first one is this A or B? An example would be, which campaign message works better, A or B? And because we're running campaigns on Facebook, we can actually tell which ones are working. Real time, change and fix. The next question, is this weird? So is this smoking pattern in this age or sex, ethnicity group expected or not? And we can see that and we can pick it up. It's beyond outliers. It's actually way more sophisticated. We can also ask how much or how many. So we can make really quite good numerical predictions around flu prevalence this year using data science. Much more sophisticated than we had before. And we can ask, how is this organized? So we can say from the data which kinds of people consume more sugar or lose weight on this app. And we can juggle with it and play with the things we're using to get the data and see how it's evolving. And finally, which is probably even more exciting, is what should I do next? So this gives you decision points in your public health programs or other interventions to see if you do X, Y, or Z, what will be the result, but also, you know, the road turns. If I do X, this will happen. If I do Y, so which decisions should I make? And once digital tools are deployed, we get data, and it's like a tap turning on. Okay, so Julian Flowers, who's up there to the right, our head of data science, he's taught me a lot about this. In fact, Julian says it's not a tap, it's a fire hydrant. And it looks like that. And that's Julian, third from the left, in his data lake, I presume, Julian. That's what you're developing there. So we get a fire hydrant, lots and lots of new data, much bigger than we're used to dealing with, way beyond administrative data screening, the stuff we're used to dealing with. It's new. This turns epidemiology right on its head. And for this, we're going to need new skills. So we'll need data scientists, not epidemiologists or statisticians, data scientists. And look at the range of skills that are included in that. Okay, this is really pushing the boundary of how we work as public health folks. And we'll also need digital skills. So this is even more complicated. It's not just about tech people. We need people with wisdom. We need people with research skills. We need people who can think outside the box. We need creative folks. And there's a pyramid as well. So some work that we're used to doing is vanishing. So as we automate some of our data production, and again, Julian's team is leading on that, and we see it also happening with genomics. Lots of people are focusing on this. There will be things we do now we do not need to do in future, and that will happen quite quickly. We will also look at a balance in power. So there's shift in power going on. First of all, we have new partners. So we've already talked extensively about mobile phones, apps, technology, startups, angel investors. When did we talk about this in public health before? But that's the reality. If we're going to do these things, these will be our partners, other parts of government, commercial companies, startups, all of these things. And also citizens. So they will be able to see what we're doing more, and we will need to engage with them one-on-one, which in a way we haven't quite done with public health before. We've come close with surveys. This is a whole new level that's opening up that we must think about. And we must, of course, also recognize there is a digital divide. So between the haves and the have-nots, who both got access to technology, but also who can interact with it, and also that the market will leave out. Apps are developed for people generally who will pay for them, and so are digital services, apart from those in government. So how do we look for the people who are left out of this revolution? Language issues, technology skills. And of course, we must engage with people. So in the end, these things, Julia, you put it beautifully, has to engage with a person who's using whatever we're developing. And this will really challenge us in a good way. It also opens the role of morals and ethics. So I liked this cartoon from Dilbert. It made me think about what Google DeepMind faced this year when actually bravely going into a new world. They came up against ethical and moral issues that hadn't been there before. And they've been, they've reviewed it, they've restructured, they've thought again. We must be engaged in those conversations because as the frontiers are pushed, there will be new issues coming up. So this is partly our responsibility to engage. And also, as we fail fast, I think that's coming across as a theme, we can't be safe anymore. We need to know how to fail fast, learn from that and move, and that's fine. And finally, couple of points. We're in a post-truth society, so we will no longer control the information. We're looking for airtime, not just for apps, but for what we say. So will we be trusted on our evidence among all the other data out there? And how do we do that? maybe we never did control information, but we thought we did. But now we really don't. So how do we work in that environment? How do we influence? How do we brand? How do we make things sticky? How do we make people listen to us? Because we will be able to measure if they're listening to us. I've given myself a challenge to learn lots of new things, so I thought I'd share with you my current interest. And I'm doing it because I find it difficult, and I do it because I find it fascinating. Blockchain is not just about cryptocurrency. Blockchain is actually about how data links and connects, and it's a great democratizing force. And I think we should be considering blockchain and how it might affect us in public health. And so I've set myself a target to submit an article to this journal, which has just started by the end of the year. And I would encourage all of you to, step outside your comfort zone and find some new thing just to learn and grapple with. You may very well find you're the first public health person there. So what's next? Okay, this is coming. Okay, in the short term, won't hit us, but in the long term, it probably will. And as I come to the end of, I've had a 2-year secondment in Public Health England, which is ending in about 2 weeks' time. I'm going to miss it all very much. So I'm not leaving the public health community, but I will be leaving Public Health England. And I thought I'd leave you just with this quote. So what's next? What's changed really is the raw computing power that we have available now. With artificial intelligence, we're actually on the brink of a change in civilization that is so huge, it represents a fundamental change in our trajectory as a species. And I think that's a good note for me to end.
So we're very happy to take questions now. It's quite dark in the auditorium, so please make a public nuisance of yourself in attracting the person with the microphone so we can see. Thank you.
Thanks very much for some really interesting presentations there. I'm just wondering how you are actually reviewing effectiveness of these apps, because the vast majority of the apps do not have, our gold standard randomized controlled trial, and many of them are people like them. Yeah, they used them, but actually, did they really help people lose weight or whatever it was? And, what's going to be good enough in terms of your benchmark?
So it's an interesting one, and that's partially why it's taken a number of years to come out with something. And I say this quite a lot. Apps and innovation doesn't suddenly sort of pop out of a box having done a 4-year randomized control trial that often costs $1 million. It's a tough one. But what we work with a panel of over 150 experts, so if any of you are interested, do get in contact, do let me know. And we look at the evidence base there. So you're right, very few randomized control trials, very difficult in the digital space. But we look at what they have got. So we say, okay, well, is it based on normal sort of accepted interventions? So is it based on standard CBT practices, for example? Or is it based on on NICE pathways, for example? So we look at what is there, and then we rate it accordingly. So gold standard obviously being fabulous, with randomized controlled trials. Others are, okay, it has got a good solid base it's on the right pathway. If it's below that and it's just completely out of the ordinary and it's not accepted and it's, they haven't got anything, then we don't actually publish it. That's one of the things that we do is we go back and say, listen, you're not ready yet, come back at this stage. That doesn't mean that they can't go onto the general app store, but they wouldn't come onto our app store. So we do take the expert input that we get quite seriously in that respect.
Yeah, I could add to that what we do, the active ingredients that are referred to are theoretically based active ingredients from the behaviour change taxonomy that's come out of UCL from Mickey et al.'s work. And so we've gone through and we've coded. You're looking very skeptical. Well, no, I think you're quite right, but, you know, the theories don't work in general in some cases, and I think the best we can do is make sure that we are having a shared language so that when we do test and we do look at what works and what doesn't work, we're comparing like with like, and we are giving it a fair trial. And what we're aiming to do, because we recognise the reality of a fully academic RCT, as much as we'd love to have that, is not realistic. What we're aiming to do is make almost mini RCTs, where we can take some of these different theoretically grounded features and functionality and test them against maybe another set of features or functionality or some sort of control and see what the difference is, but do it in a much shorter cycle, which is what we're talking about. And of course we're balancing between commercial reality and academic rigour and trying to strike a middle ground.
A further comment is that I know the academic community is now beginning to invest in evaluating innovation in public health more generally, of which digital is part. And certainly is a recognition that we do have an evidence gap, and it's very pleasing to see that they're not only looking at the particular topics, but they're also considering innovation in methodology to give us a robust evaluation.
Yeah.
Are there any more questions? Yes, there's a gentleman there in the middle. If you could just wait for the microphone, sorry, just so everyone can hear. It's coming down.
I would like to thank everyone in the panel. I mean, it was very fascinating. But I would like to stop. Basically, I'm from Public Health Southwark team. On David's, what he sort of showed us was quite interesting, because I think if we wait to see and deal with complexity of programs in public health and build on evidence, time will sweep us by. Basically, what you found there with the rugby players, I think, is the music that 6 to 9 years old want to listen. That's now, we have a case study there, and we have what is called building evidence as we progress. So if that's successful, it has to be copied elsewhere. So I think that was a very good model.
Well, yeah. That's very kind. With it's easy for me. I'm not a public health individual expert in any way, shape or form. So going back to kind of apologising later, and I think it's kind of answering the lady's question around the app as well in terms of the evidence base. Someone's got to make it, and I do know that if I don't get my 10,000 steps in a day, I'm obsessed. I was never obsessed before. And why? I don't know why I've become obsessed, but I've got this bloody thing on my wrist, and now I'm obsessed with it. So there's been an interaction there, difference, and I'm actually fitter for it. I've reduced my heart rate down from, I'm not going to tell you. So, but to your point is, when it's easy. I don't want to sound, you've got to have that evidence base, and you've got to have the evaluation. All that's being checked out by John Moores and evaluated through John Moores. So we've got to have that academic kind of, that critique around it. But it was a punt. In a lot of respects, it was a punt. It was kind of, feels like a good idea, this. And a lot of the time, it feels like a good idea. It genuinely is. Now the rugby clubs have all started, they come together. Individually, they were bidding against each other, okay, for pots of cash that doesn't exist. So right across the M62 corridor now, you've got every Super League club have come together. They've called themselves a vanguard, right? Just because everybody else is. So they've called themselves the Rugby League Vanguard, and now they're one club. So I said, I've pitched to every chief executive and coach and just said, you can knock 7 shades out of each other on the pitch. That's great, because that's kind of what you do in rugby league. But off the pitch, you've got to come together. You've got to collaborate. Murray's point, you've got to come together and collaborate. And now they've got a voice. Rugby league has now got a voice, and it does tap into a certain part of our populace. And so they're coming together for bigger bids now and being much more. But the interesting thing, I think, for public health there, is that they're using the JSNAs, and they're using the methodology and the priorities that are set by the Health and Wellbeing Boards, and they're targeting those priorities across the 62 corridor. So watch this space, you know, because there could be something in that. And I think the more we grow the digital offer in that M62 corridor, Northern Powerhouse, come on, that's the future.
Yeah, I would say I'm willing to volunteer to come to Widnes to work with the rugby team anytime. So,
Me too.
yeah, we'll be there. Just on the issue of apps, and I'm glad it worked for you, but I found another subset where women did it and found after 10,000 steps they had to have a cake to reward themselves. So it's back to evidence, your point, you know, you have to watch this very carefully and see the evidence. And I think another word of caution, the reason we have to be in this field is to see how it grows, because we have to be engaged. With the cuts to public health, there is a pressure to do things cheaper, particularly in local authorities. And there is a risk, potentially, that people will grab something that looks digital, looks cheap, that someone else has developed, and deploy it, and tick the box that they've provided a public health service. Okay? So this is one reason why we need to be in the game, because we need to be clear about what is working and what isn't, because most of the apps out there don't work. The top selling apps are rubbish, right? They really are. So this is why we have to be involved, not because we're perfect, but because the alternative is such crap, frankly, that we have to be engaged in the dialogue, and we have to really also watch this issue of, you know, jumping onto a digital bandwagon, which may actually be the wrong decision, and a service may be destroyed, and you can't go back then. So this is why we have to be engaged.
Thank you. I think we had a question at the front.
One for Julie. You kind of answered the question already a little bit, Mary, but maybe more precise on the numbers. How many apps out of the 250,000 or out of the health apps that are available would you estimate, given your experience, are actually going to pass that threshold point? What kind of quantum are you thinking it might be?
If I was to take a sort of rough stab in the dark, I'd say about 5% or less.
I'd say less.
Yes. And then we have another question just behind.
Hi, just a quick one about the apps again. One is around a number of apps that we have that are kind of more scientifically based, maybe, are based on iterations. So they're working with who's using that, trying to work out how to tailor that more effectively for different populations. How will that be recognised within the endorsement process? Because you endorse it at one point. So I just wondered about how that works over time. And my other question is there something that you're considering about how we collaborate with those that are endorsed in regards to the data that they're collecting? Because that could be some really rich data sets that would help us understand what's going on with various groups within the population for particular issues or things.
Yeah. So can I answer the second question first and then come back to the first? So actually, you're right. And there's actually lots of app companies out there that are really willing to engage for research purposes, because they know that they're collecting an awful lot of rich data. They are collaborating either individually with universities, they're being approached, or their very essence of being was that they were set up to gather research in the first place. So there's an awful lot of companies that are doing that, and there's an awful lot of companies that are gathering that data that now want to say, okay, well, we realise what's happening here, we realise that we now need to prove that we are good, and so they are looking to get those trials, they're looking to build up that evidence almost retrospectively. So they are looking to do that. So anybody out there, you know, if you are looking to engage with apps, come and let us know, because we can put you in touch with apps that can, you know, that I'm sure will help. So there's an awful lot of that going on. There is, I talked earlier about something called GDPR. So there is another interesting part of it, which is, okay, how transparent are you, and are you getting the right consents about what you're doing with the data as the app developer. So there is some work to do there. You can't just go and get a data set depending on what it is that you're wanting. So there is some work to do to make sure that people are aware that they are taking part in a study. Having said that though, when Apple first launched Apple Health Kit, one of the big sort of case studies that came out of that was that they were able to get 30,000 users consent to share their data within the first 2 weeks. And Stanford University said, otherwise that would have taken us months, years to get that sort of, engagement. And we're seeing that time and time again. People are very willing to consent for their data to be used for research purposes, in particular if it's anonymous, but it helps further insight into a particular condition or public health in general. So both individuals and the developers are really up for that.
Any further comments?
I'd just add that that's something that we've found as well, that people are really quite happy to share their data. I think if you're very transparent and they trust you as an organisation and you're very clear about what you're using that data for, I sometimes find it fascinating how much time and energy is devoted to discussing personal data protection when actually people who are the ones that are sharing the data in the first place are rarely consulted, and they generally are up for it because they can see that it's going to advance the field and it's going to help them ultimately.
So the next session starts at 15:40, so you can either look at your timetable in your booklet, or there'll be locations will be announced. So the sessions will be targeting smokers in the healthcare system in Chancellors. The air pollution is in Woods Scowen, cancer data and outcomes in the Helen Martin studio, and the global burden of disease in the cinema. The session on the STPs is here, and health and employment in the studio theatre. So thank you very much.